This session is on preparing for end of life on the dementia journey and is intended for anyone impacted by dementia. This session will help you to understand what to expect in advanced dementia through the various transitions to end of life. We will review end of life decision making, some strategies for navigating these conversations, and some common terminology that you may hear when you are speaking with healthcare providers. We will also review some of the impacts that the end-of-life stage may have on the caregiver, the physical signs of end of life for the person living with dementia, comfort measures, and what you might expect when the death occurs. To start, we need to recognize that dementia is a life-limiting illness. That means that the physical consequences of dementia, like decreased mobility and an eventual loss of the functions that sustain life, like eating and breathing, can eventually cause the person's life to end. Other times, and quite commonly, the person living with dementia may not actually die of dementia, but rather another condition that causes a rapid deterioration in the person's health, such as heart failure, cancer, or another comorbid condition. The functional decline caused by dementia can make an individual more susceptible to these conditions. Pneumonia, for example, is a common condition that can become fatal for a person living with advanced dementia. So while not necessarily dying from dementia, a person may die from a condition that is complicated by dementia. And we'll talk more about the physical signs of end of life later in this presentation. The topic of death and dying is one that we tend to not talk a lot about in the Western world. However, it would be fair to say that most of us have some idea in mind of how we would like to die. And in most cases, this is what frames our idea of what a good death looks like. In the hospice and palliative care literature, there's a lot of discussion about what we mean when we refer to a good death. So recognizing that our individual perspectives are the most important driver of what this looks like for each person, the Institute of Medicine published a general definition that gives us a frame of reference to think about. So they suggest that a good death is one that is free from avoidable distress and suffering for patient, family, and caregivers, in general accord with the patient's and family's wishes, and reasonably consistent with clinical, cultural, and ethical standards. So in other words, it's about being comfortable, having your wishes heard and met where possible, and having your cultural practices and values respected. Advanced care planning is our way of increasing our chances of having a good death. Evidence supports that when wishes and decisions are contemplated, discussed, documented, and shared in advance, an individual is more likely to die in their preferred place of death. Advanced care planning and talking about what a person wants at the end of their life may also help support individuals and their families to face their mortality while honoring the right of the person to have a say in what is happening. And because we can't predict what a person's wishes are, having these conversations early on allows the person living with dementia to express their wishes well before the advancement of their dementia. So as difficult as it might be to discuss death, it is important to talk to the person with dementia about their wishes for end of life. And we also recognize that not everyone who is watching this video right now may have had the opportunity to have had these discussions earlier on in the dementia journey, or perhaps you are faced with making these difficult choices now that you may feel unsure about. Use your knowledge of the person you are supporting and what decisions you think they would make for themselves now if they could. And consider this alongside some of the criteria that we mentioned earlier regarding what a good death is generally thought of for many people. This information, along with any recommendations from healthcare professionals that may be involved, can help to guide your choices at this stage. If you are still in a position to have these conversations, we know that for most people, talking about end of life is difficult. but you may actually find some relief in having the subject out in the open. Talking about it early on not only helps you to understand what the person's wishes are, but it can also help you to face your worries together. Before starting the conversation, you might find it helpful to take some time to think about how you want to approach the topic. Drawing from your prior experiences of difficult conversations with the person can help you to identify some unique to you approaches that can help to reduce the tension or the pressure, like using humor or even just acknowledging the difficulty in talking about end of life. It can be a very upsetting conversation to have, and it's okay to express your emotions, including your sadness. And know that there is no right or wrong way to approach the conversation, and you don't have to talk about everything all at once. You might find that giving space for the conversation to open and close at different times, and having the conversation in small pieces rather than a lengthy discussion, may actually allow for more self-reflection and progress for both of you. Remember that this is a conversation about you and your family member. So encourage the person who is living with dementia to be involved in it as much as they are able. If the other person refuses to talk or changes the subject, you can try saying something like, "That's okay, we don't have to talk about it right now, but it is something I'd like to talk about soon. I just want to be sure I know your wishes so they can be honored when the time comes." You could also try framing the conversation around your own personal planning. So for example, "Mom, I've been doing some of my own personal planning lately, and my kids have found it really helpful to know some of the things that I would like if anything were to happen. And I just realized that I don't know what you would like. Perhaps we could have a similar conversation." Some topics you'll likely discuss when you're having these conversations include the type of medical treatment that you're comfortable with. So for example, what type of pain treatment or control do you want? Do you want to be resuscitated? If you can't swallow, do you want a feeding tube placed? Where do you want to be cared for? At home, in long-term care, in hospice? Regarding your activities of daily living or your daily life habits, what are your likes and dislikes? So for example, what razor do you prefer? What side do you sleep on? Is it important to you to have a certain pet nearby? What brings you joy and comfort? For some people, this might be having a song or a genre of music playing, and for others, it might be having a clear view of the birds and the trees outside. Think about what you want your family and friends to know or remember about you. What accomplishments are you most proud of? What are your favorite memories that you want to be reminded of? What insights or life lessons are important for you to pass down? So I've just listed a few questions that you might like to address in the conversation, but I also want to note that some people might be uncomfortable with these types of questions if they're delivered directly. So it can be helpful to consider approaching the conversation with a bit of a lead-in. So something like, "I wonder, have you thought about what you'd like the end of your life to look like? What would the room look like? If you could envision it, who would be there? What do you think would give you comfort at the end of your life?" So with these more general lead-ins, some might find it easier to envision their preferred space and the comforts that go along with it. And in having these conversations, it may be helpful to ask the person making these decisions just how strongly they feel about these topics. So for example, even if an individual's preference is to be cared for at home, if it is not the safest choice or their medical needs cannot be met at home in the future or while they're palliative, what would their second preference be? And how important is this decision to them? Ultimately, having knowledge of and acknowledging these topics can help in improving the quality of life when the person with dementia can no longer express their preferences. So by acknowledging where your family member wants to be, how they want to be positioned, the songs they want to listen to, the medical interventions they're comfortable with, and the people or the pets that they want around them, we can help them to have a good death. If advanced care planning was not done, then it's important to make decisions in the best interest of the person living with dementia. The progressive nature of dementia means that most caregivers will have to make hard decisions at the end of life. Some of these decisions may include who will provide the personal care? Will the caregiver take over the person's washing, dressing, toileting, and feeding? Or will this personal care be provided by healthcare workers? Where will the person live and what type of support will be needed? So you will likely need to think about placement in long-term care or arranging extended home care, and if the person will need palliative care at home or in hospital, or if you want to use hospice care. Another question would be, when should an advanced care plan be initiated, and what is involved when this happens? And you might also be faced with treatment decisions related to hydration and the potential use of a feeding tube, nutrition, intravenous tubes, CPR, transfer to acute care settings, the use of antibiotics and pain control, and advanced life support like a breathing tube. So it's very important that any decisions made should be made in the best interests of the person living with dementia, with consideration given to the person's known or perceived wishes, beliefs, and values. Conflict can arise among family members when individuals may have different values or a different interpretation of their culture and of the perceived wishes of the person living with dementia. So having this documented is the tremendous value in having these discussions early. Putting in place an advanced care plan, including a representation agreement, can help to ensure that the person living with dementia has a choice in their end-of-life care. I want to share this quote with you from a previous client of ours who was living with dementia. Even towards the very end, I hope still to have some joy. So if we have the difficult conversations early on, we can put the plans in place that allow us to honor the person all the way through to the end of their life. Before we dive deeper into what end of life may look like for a person living with dementia and how we navigate the transition from advanced dementia to end of life, I want to start by reviewing a few key terms that we will be using in this presentation that you may hear in your conversations with healthcare providers, and it can be helpful to have a general understanding of what these terms mean. So when healthcare providers are discussing end-of-life care, they're typically referencing patients who are likely to be in the last year of their life, and this identification can be helpful for planning and supporting the person's care. When a person is actively dying, they are very close to death and are in the final phase of the dying process. This stage of dying can last for approximately 3 days, but this is only a guideline and it can vary widely by individual. It's also likely around this time that you'll be involved in conversations about comfort measures. So these are the ways that an individual's suffering can be eased during end of life. And this can include pain and symptom management, which is intended to comfort the person, not to accelerate death. Another term that you may hear used around discussions of comfort measures is person-centered care, which is a philosophy that recognizes that individuals have unique values, personal history, and personality, and that each person has an equal right to dignity, respect, and to participate fully in their environment. Taking a person's individual wishes and preferences into account when having discussions about comfort measures and care is one way in which person-centered approach can be maintained at the end of life. Within end-of-life care, there are further distinctions into the types of care available to support the dying person and their family. Palliative care is a holistic approach to care that is focused on enhancing comfort and quality of life for patients with a life-limiting illness like dementia and their families. And this is done by actively treating the person's symptoms and any complications, by helping families to make the right choices for care, by providing psychological and social support to the person and their family, and by providing spiritual care. And palliative care can be delivered in the hospital, long-term care, hospice, or at home, and is applicable from the point of diagnosis all the way through to bereavement. It's even been shown that those who access palliative care early on in their disease experience less depression and anxiety, better symptom control, better quality of life, and in some cases, a longer life expectancy. Hospice care is similar to palliative care, and in Canada, these terms are often used to describe the same thing, which is the approach to care. So the difference between hospice and palliative care is that depending on where you're located in the province, hospice care is more often used to describe care that is offered in the community rather than in a hospital. So if you're interested in learning more about palliative care or hospice care and what other options are available to you, then I encourage you to check with your local health authority or visit the BC Centre for Palliative Care's website. And lastly, terminal care refers to the care provided to a person who is actively dying. So this care is focused on maintaining comfort and supporting the family in the final hours, days, and possibly weeks of the person's life. So as you're watching this video, I'm sure you may not be surprised to hear that people living with dementia have significant healthcare needs at the end of their life. And the cumulative loss of cognitive and physical function can be very stressful for the caregiver. It can be difficult to make decisions about end of life for the person you are caring for, and this can be compounded by the relationship with the person. So for example, while adult children may share caregiving responsibilities with siblings or other care providers, if they are able to, and these resources are available to them, some do not. And a spouse may feel that they need to do it on their own or are more likely to provide care for longer before accepting formal assistance like home support or palliative care. Regardless of your caregiving role, caregivers experience a number of primary stressors which are directly attached to their caregiving role, like changes in the relationship between the caregiver and the person living with dementia, or changes in the person's functional and cognitive abilities, or changes in the person's behavior or emotions. Caregivers also experience secondary stressors, which are associated with the way the primary stressors of caregiving affect the caregiver's life outside of their caregiving role. For example, the strain of needing to make decisions on behalf of the person living with dementia, the impact of their caregiving role on their usual activities, like work or self-care or their own healthcare needs, the strain or conflicts on family and friend relationships, or feelings of guilt, and often the caregiver's loss of their own identity outside of caregiving. So if any of these stressors resonate with you, you're not alone in feeling this way. These are topics that come up all the time and are common for caregivers of a person living with dementia. Throughout the dementia journey, caregivers may experience grief, loss, and guilt while caring for a person living with dementia, and this is especially felt at end of life. These feelings may manifest into a number of health consequences for the caregiver, including physical fatigue or exhaustion, depression and anxiety, an increased susceptibility to infections or disease as a result of the chronic stress on the body, and an increase in maladaptive behaviors like smoking, poor diet, or alcohol. So if you'd like to learn more about the types of grief experienced by caregivers of a person living with dementia or ways of coping with the guilt, we'd recommend watching one of our recorded videos on this topic or calling us to speak with a staff member. As dementia progresses, individuals are likely to experience complications associated with their condition, and this often marks a transition from advanced dementia to end of life. When a person transitions to the end-of-life stage in dementia, they may experience any of the following physical symptoms: an increase in comorbidities like hypertension or diabetes, behavioral changes like increased hallucinations, delusions, or restlessness, increased confusion or delirium, An increased susceptibility to infections, often due to immobility, incontinence, and swallowing difficulties. So, for example, urinary tract infections or chest infections, pressure or skin ulcers, and most commonly pneumonia, which is the cause of death in about 2/3 of people with dementia. The person may experience nausea and vomiting or physical pain, often due to a lack of mobility. So try to be mindful of any nonverbal indicators of pain, like grimacing or flinching or other behaviors. And there's often urinary or bowel incontinence, which can result in unfamiliar and possibly distressing smells for care partners. If this happens, you may find it helpful to put some Vicks Vapor Rub or some eucalyptus oil under your nose, which can help you to cope. There's also a change or decline in eating habits, where the person may be unable to coordinate chewing and swallowing, which can cause them to cough and choke. This can be distressing to the person, and it can also lead to aspiration pneumonia as small amounts of food or liquid enter the lungs. The person may also stop eating or drinking. Now, when this happens, it's important to know that the person is not starving to death. It's just that the body no longer requires the same amount of energy as their functions begin to stop. Breathing will change to shallow breaths, or there may be periods without breathing that can last a few seconds up to a minute. So at this time, there may be gas for breaths or a loud gurgling noise in the throat because of the secretions settling deep in the throat. Now know that this is a normal process, but it can be very frightening for the care partners to hear this sound. You may also see a stiffness in the person's arms, hands, and legs, and their limbs may feel cold to touch, and they may spend more of their time sleeping or become unconscious at times. So at this time, quality of life needs to be considered, and decisions about care should not be based on survival alone, but the burden and the benefits of various treatments, the degree of suffering, and the individual's overall quality of life based on what you know to be important to them. So this is when the person's known or perceived wishes should be taken into account. The use of medications at this time are usually limited to managing pain and discomfort, such as nausea or breathlessness. Now, if you're unsure if the person with dementia is in pain, observe their behavior for signs of distress, like moaning, signs of anxiety or restlessness or crying. And it's also important to ask the person about their pain, regardless of their cognition level, as their total awareness of pain may also consist of the social, psychological, and the spiritual dimensions of suffering, not just physical. The best thing that we can do for a dying individual is to preserve dignity and provide comfort measures. We all have fundamental and universal needs throughout our lives, and these needs are most significantly felt during times of vulnerability, such as at the end of our life. So if you remember back to earlier on in the presentation, we talked about what a good death looked like. And for many people, this means being comfortable and without pain, being treated as an individual, and having their dignity and sense of personhood respected. Even if the person living with dementia may no longer recognize you or seem to be aware of you during the last stage, your presence is still a comfort as they go through this last transition at the end of their life. So although people living with dementia may not be able to communicate their needs directly to you at this time, they do retain many of their physical senses, even if these senses are in an altered or a diminished capacity. So touch, scent, sound, and sight are all senses that you can use to maintain a connection with the person, create a meaningful environment, and help to maintain their physical comfort at end of life. Here are some practical ways that you can increase comfort during this stage. Keep a peaceful and a comfortable environment. So be mindful of the temperature and use fans to help with fever or breathlessness. Speak calmly and naturally. So recognize that you may be feeling anxious or scared or upset during this time, and this can translate through your voice. So as much as possible, try your best to stay calm and avoid loud or panic speaking. Also try to be aware of your facial expressions and your tone of voice. The last sense to go for people living with dementia is typically their hearing. You might find it helpful to engage in a calming activity with the person, which can benefit both of you. For example, a gentle massage of the person's hands or feet with some scented lotion to incorporate a familiar scent. But just be mindful that while some scents may be enjoyable and evoke pleasant memories of the past, others may be more unpleasant to the person. So for example, while I personally love the smell of roses, I know that my mom cannot tolerate it. So if I were to give her a gentle massage at this stage in her life with a scented lotion, I know that it would have to be lavender, never rose. So this is where your knowledge of the person and their likes and their dislikes can really help to provide that person-centered care. And you can also incorporate sounds by softly playing music that the person has enjoyed in the past, or reading aloud to them, or just reminiscing about past events. You can hold their hands and just reassure the person that you're close by and that they're safe and cared for. If breathing is difficult for the person, you can raise the head of the bed or raise their upper body with pillows. And you can also reposition them to relieve the pressure areas to prevent pressure ulcers or bed sores. Just be mindful to use slow, gentle movements and only move one part of the body at a time, and follow their lead. If you notice them wince when you try to move them, stop and try again later or ask someone else for help. Be mindful about lighting and what is in the person's line of sight. So for example, if their head is positioned to only look up at a ceiling, then reposition them so important objects are in their direct line of sight, or so they get to look at pictures with bright colors and contrast. For lighting, use a brighter lighting for the daytime and lower intensity lighting for sleep. And try to be mindful of any glare, such as from windows or shiny floors. If the person is no longer accepting food or drink, you can keep their lips and their mouth moist with a wet cloth or a sponge, and ask for direction on how to keep their teeth, tongue, and the inside of their mouth clean. Lastly, do your best to help staff provide comfort measures to the person. So you can do this by speaking with staff about the person's life stories so they can connect to the person, and also letting staff know about any beliefs or customs that may be required at the time of death so they can do their best to make sure that they're honored. There are a number of things that may happen following the person's death. After the death, you'll say your last goodbyes. There is no right or wrong way to say goodbye or to grieve. If you were not with the person when they passed, you may choose not to see the body or to say goodbye in other ways. If the person died at home, you'll have to contact the funeral home. If they died in hospital or hospice, the staff will contact the funeral home on the family's behalf. Remember that as much as you want to be with the person when they die, sometimes the person needs the space to let go. Or there may be other reasons why we cannot be there in person, such as being at a distance. And some people will wait until you leave, while others may wait until they see those that are most important to them. We do not get to choose when and how this will happen. And how you choose to cope after the person with dementia has died is very individual. Also keep in mind that the pandemic may impact and still may be impacting some of those rituals that we tend to do that occur around a person's passing, like a celebration of life, a funeral, or other rituals. Now, if this is the case, try to find alternative rituals to express your grief and allow yourself time to grieve. Okay? We grieve because we love. And while you never forget it, you can learn to manage it in time, and you can learn to honor the person on the days that bring you memories of them, like on a birthday or an anniversary. And you may find it helpful to talk to family and friends, or to join a bereavement support group if one is available to you. Try your best to honor all of your feelings. That can include relief that it's over, anger that it happened, or sadness that the person is no longer with you, or even apprehension about a life without your person and having to move forward with a new normal. So I know that I've just covered a lot of information that may have been very difficult for you to hear. And at this point, you may be feeling like you don't know when the dementia journey will end or how you might cope when it does. So I just want to share with you this quote from Fred Rogers. Anything that's human is mentionable, and anything that's mentionable can be more manageable. When we can talk about our feelings, they become less overwhelming, less upsetting, and less scary. And the people we trust with that important talk can help us know that we are not alone. So I'm just going to take this opportunity to remind you again that if you need to talk to others going through this, you are not alone. You can call our First Link Dementia helpline and we can talk through it with you and connect you to bereavement resources. And while you're actively caring for a person with dementia, we have support groups both in person and online where you can connect with other caregivers on the same journey. In the helpful resources document that accompanies this video, you'll find links to a number of documents and websites to help you at this stage in the journey. This includes a personal planning checklist, comprehensive informational handouts on dementia and end-of-life care, and links to the BC Centre for Palliative Care's website, the Ministry of Health's website, and NITIS, which is a nonprofit organization devoted to personal planning in BC. Now, if you'd like more information on the services available to you and how to work with home and community care, we also have a recorded video and offer a workshop on accessing services. Or you can also follow up with staff on the First Link Dementia helpline and we can talk through it with you. If you would like to speak with a staff member to ask a question or just to talk through your situation, please call our First Link Dementia helpline. Our English line is available Monday to Friday from 9 a.m. to 8 p.m. at 1-800-936-6033. That's 1-800-936-6033. We also have services Monday to Friday from 9 a.m. to 4 p.m. in Punjabi, Cantonese, and Mandarin. Please check out our website for more information on this topic.